Hi, today we're going to talk about our exemplar of perfusion with coordinating care for patients with cardiac dysrhythmias. First, let's just do a little overview about our cardiac system. So we know we have a conduction system that begins within that SA node and produces that electrical activity that causes our muscular contractions in the heart, which produces our waveforms. Within our waveform, we have a P wave, a QRS complex, and a T wave that we will recognize. Um, some of the risk factors for patients with dysrhythmias. So we have patients depending on age, maybe myocardial infarction, hypertension, heart valve disease, heart failure, cardiomyopathy, infections, diabetes, sleep apnea, patients with recent heart surgeries or procedures, electrolyte disturbances, any use of drugs, alcohol, tobacco, and then different medications can have toxicities such as digoxin that can cause dysrhythmias. So, a little pathology, we know that dysrhythmias is caused from a disruption in that cardiac conduction pathway or that electrical pathway, and it's a deviation from the normal rate or a normal sinus rhythm. So looking at our EKG strip, this is showing an example of a 6-second strip. So when we break this down into the little boxes, each little tiny box is zero point 0.4 seconds, which makes each big box has 5 little boxes, and that's 0.20 seconds. So 15 of these blocks would be 3 seconds, or 30 of these blocks would be 6 seconds. So that's where we're getting a 6-second strip that we can count our heart rate, because we would multiply the QRS complexes that we see in this strip times 10 to get our 60 seconds. So just some of the things on the waveform that we kind of expect you to look at and recognize. So we have a P wave that corresponds to the atrial depolarization that's produced through the SA node into the atria. We have a PR interval that begins with the beginning of the P wave to the beginning of the QRS complex. We have a PR segment, and this is immediately following the P wave to the beginning of the QRS complex. The QRS complex, of course, responds to the ventricular depolarization, and that ventricular contraction occurs after the QRS complex in that ST segment, and that ST segment is typically what we're looking at when we're looking at patients with heart disease or an MI. Your QRS interval reflects the time required for that ventricular depolarization, and our T wave corresponds to the ventricular repolarization. Atrial repolarization is occurring during this ventricular contraction. And the QT interval reflects the time that is required for that ventricle depolarization and repolarization. This is just another little shot that shows the different intervals that we're looking at. When we're looking at the PR interval, again, this is measuring that time of depolarization. Your PR interval for a normal rate or a normal sinus rhythm would be 0.12 seconds to 0.20 seconds. Your QRS interval is a normal for a normal sinus rhythm, 0.06 to 0.10 seconds. And then your QT interval that's shown here. There's not a specific value that we associate with the QT interval. So when we're looking at dysrhythmias, how are we going to interpret that? So here is just a nice step for you to go by and look at. So number one, is the rate regular? Is it fast? Is it slow? Is the rhythm, each QRS complex, normal? Are the P waves present before each QRS complex? Is there a QRS complex present? Are there T waves present? How do they look? And what are the intervals? Are they in normal limits? Is there P waves that are present before each QRS? And is there a QRS with every P wave? So we can take these questions and look at our strips to determine if it is normal and possibly be able to analyze what kind of rhythm it is. So when we're looking at calculating the heart rate and the regularity, Again, I talked about when you're looking at a strip, you go by a 6-second strip and you count your complexes within that 6 seconds, multiply it by 10, and that's going to give you an average of a 1 minute heart rate. So looking at this one, we know that the complexes, there are 6 complexes in that 6 seconds. So we multiply that times 10 and we have a heart rate of 60. When we're looking at the regularity, we see that it is very regular. It's occurring at the same time. You can always get your calipers out to measure to make sure that you're falling in the regular heart rate. Basic cardiac rhythm. So we have a normal sinus rhythm. We know that rate is between 60 to 100. We have a P wave with every QRS complex, and then we have a T wave that follows that QRS complex. It is completely normal. This rhythm strip is not showing any extra beats, any abnormal beats, and we see that it is completely within those limits. Looking at sinus bradycardia. So sinus bradycardia is a sinus rhythm. So we know we have sinus rhythm has a P wave with every QRS and a T wave that follows that QRS, but the rate is less than 60. Some of the causes could be from hypoxia, hypothermia, but it could be from people that just are that way. So maybe if your patient is asleep, you could have a rate that falls below 60. Or athletes, typical athletes tend to have a lower resting heart rate. So some of the things we want to know about this is, are they symptomatic? Does this require treatment? If a patient is asleep or it's a regular resting heart rate for an athlete, they're not going to be symptomatic and we're probably not going to be treating this. But if they are symptomatic, one of our major treatments we do for bradycardia is atropine. For sinus tachycardia, again, we know we have a sinus rhythm, so we have a P wave with a QRS and a T wave, but this rhythm is greater than 100. Some of the typical causes of sinus tachycardia can be fever, anemia, hypovolemia, hypotension, our body's trying to compensate, a pulmonary embolism, or even a myocardial infarction. Some of our typical treatments is looking at what that cause is. If the cause is due to a fever, we're going to treat that fever and that should take care of the tachycardia. If it's due to anemia or a hypovolemia, we want to give fluids to help replenish that fluids and that should take it down. But we might also use medications such as beta blockers or calcium channel blockers, which will decrease your heart rate with that as well. So in this rhythm strip, this is showing us an example of a sinus tachycardia. Premature atrial contractions. So this is an ectopic atrial beat that occurs earlier than the next expected sinus beat. So it is usually asymptomatic and benign, but we do have to monitor it and make sure that it's not being repetitive and not occurring frequently because it can be an initiative of SVT. It is more common in older adults, and sometimes it is, as like I said, a proceeding to a more serious dysrhythmia. Some of the causes could be hypoxia, excessive stimulant ingestion, infection, digoxin toxicity, or coronary artery disease. And our treatment, due to it not being necessarily symptomatic, we're going to monitor that frequency and possibly try to eliminate that cause that's causing it. If it could be from excessive stimulants or an electrolyte imbalance, we want to monitor that and fix that cause. So as you see in this example, it is pointing out the PAC. And if you look closely, you see that this strip looks like a sinus rhythm with that extra beat that is occurring early than it is expected. Next, we are going to talk about another atrial dysrhythmia, which is atrial fibrillation. AFib is the most common dysrhythmia in older adults. It increases with age and heart disease. And a big thing with atrial fibrillation is we have that extra atrial beating, and so we have a tendency for that atria not to completely close because of that fibrillation. With that atria not completely closing, we have a risk of building up or pooling blood in that atria and then building up clots in that atria. Those clots can then be expressed down through the ventricles and out to systemically to the body. And at this point, our patients could be at a high risk for clotting, strokes, MIs, pulmonary embolisms, and such. So, one of the big treatments with afibrillation would be to be on a blood thinner, as we want to prevent those clots building up. So this just shows you some of the different causes that could cause atrial fibrillation. Our treatment, again, we're going to want to control that rate. Typically is used with digoxin or beta blockers, calcium channel blockers. An antiarrhythmic medication such as amiodarone could be used. Many times they might try to do a cardiac ablation, which will reset and hopefully put the patient back into a normal sinus rhythm. Same thing with the synchronized cardioversion that you would do with atrial fibrillation. Here is just a couple strips that is showing some examples of atrial fibrillation. Strip A shows a controlled AFib. We see that there's not one distinct P wave, but multiple atrial contractions between your QRS. And then in strip B, this would be considered an uncontrolled atrial fib with rapid ventricular response, or you would see that as RVR. So when you're looking at this strip, you can't determine a P wave before each of those QRSs, and the rate is typically faster. So what sometimes they might do is try to slow this heart rate down to be able to analyze it a little better to see if it's sinus tach versus AFib. Next, we'll talk about atrial flutter. So atrial flutter is very similar to AFib. It is, again, an atrial rhythm that is produced outside of the SA node. Causes can be from acute MI, mitral valve disease, thyroid toxosis, COPD. And treatment is very similar to atrial fibrillation. We want to make sure we're controlling that rate. Digoxin, beta blocker, calcium channel blocker, use of antiarrhythmics and cardioversion. And again, we want to make sure that we're controlling any blood clots. So typically these patients are on some sort of blood thinner. Here is just an example of that atrial flutter. So the difference between atrial fibrillation and atrial flutter, you see that that P wave is a little more distinct, and we kind of see that, and it's called like a sawtooth. Here is the next one we're going to talk about is supraventricular tachycardia. So supraventricular tachycardia, when you're looking at this, it is a fast, regular tachycardia with narrow QRSs in that complex. It usually originates above the ventricle. Treatment is typically due to treating the cause. Some of the reasons why we see people that go into SVT is due to stimulant use, infections, hyperthyroid, or heart disease. The treatment we're going to try first is doing a vagal maneuver. So a vagal maneuver is when you have the patient bear down like they're having a bowel movement and try to reset that heart rate. If that doesn't work, we might try using adenosine, which that is a medication that has a very short half-life, but we're going to get it in super fast and flush it fast. And we can go in with 3 doses of 6 milligrams, 12 milligrams, and 12 milligrams repeated. And if that doesn't work, we're going to do a synchronized cardioversion. And just remember, a synchronized cardioversion, we are doing electrical cardioversion to the patient. So if they are stable, we are going to want to give sedation if possible, make sure we have a consent for that, and they need to be on a monitor with a crash cart available. The reason we do synchronized cardioversion versus just a regular defibrillation is because if we were to hit the peak of the R, we could cause this patient to go into ventricular tachycardia or ventricular fibrillation. So we want to make sure that it is synchronized and it is hitting at the right point to cardiovert these patients. So premature ventricular contractions, this is a extra beat, kind of like we talked about premature atrial contractions. This is an extra ventricular contraction. Many causes are hypoxia, MI, cardiomyopathy, or an electrolyte imbalance. And treatment is typically aimed towards correcting the cause and using antiarrhythmic therapy. Um, Again, if the patient's using stimulants or you have an electrolyte imbalance, we're going to treat that. Typically, we see a lot of PVCs with potassium levels that are out of range, so we might possibly need to replace that with oral or IV potassium, or if the potassium is high, use K-exolate to help decrease that potassium level. Um, we're going to monitor the frequency of them because, as well, with multiples of PVCs, the patient can run risk of going into ventricular tachycardia. So here's a couple of examples of the TAC. As we see, they can be the same way as it shows in the first one. In the second one, you see two different types. In the third one, two different types. So they can be called multifocal, meaning they're originating from two different spots. And again, here is another little set of strips with premature ventricular contractions. That first strip, you see three together. That would be like a triplet of PVCs or a run of PVCs. In the second strip, you see where it has a PVC occurring every other beat. We call that bigeminy. And in the third strip, you see where that PVC is occurring every third beat, and we would call that trigeminy. So in ventricular tachycardia, this is when you have three or more PVCs in a row or a run of those PVCs that does not break. Some of the causes of ventricular tachycardia would be hypovolemia, hypoxia, acidosis, hypokalemia, hyperkalemia, hypoglycemia, hypothermia from toxins, a cardiac tamponade, MI, or a PE. So treatment is, do they have a pulse? If ventricular tachycardia has a pulse, we want to get antiarrhythmic medication in them as soon as possible, possibly have that electrolyte replacement, a cardioversion, and fix the cause that's causing it. If your patient does not have a pulse with VTAC, we want to start cardiopulmonary resuscitation and defibrillation as soon as possible. Here is some examples of ventricular tachycardia, and of course, as we see, this can be life-threatening. Your body cannot have cardiac output with this type of a rhythm, so it is life-threatening. We have significant loss of cardiac output, and death would occur. Ventricular fibrillation. This is a lethal dysrhythmia. This is kind of what precedes a death. So it causes, again, similar to the ventricular tachycardia, hypovolemia, hypoxia, acidosis, hypokalemia, hyperkalemia, hypoglycemia, hypothermia, toxins, cardiac tamponade, MI, or PE. And treatment is immediate chest compressions and immediate defibrillation as soon as it is available. Again, you want to, when you see this rhythm on a monitor, this is an example of what it's going to look like. You want to check your patient first, okay? So check your responsiveness of your patient. Make sure that maybe it's not just the electrodes that are messed up on their chest. So always check your patient for responsiveness. Are you okay? Are you okay? If they do not answer, check for a pulse. If there is no pulse, you want to begin CPR immediately. Call for a defibrillator and defibrillate as soon as possible. With a myocardial infarction and MI, I know you guys talked about this in 200, but just a little overview. We want to make sure that we are doing medical management, maximizing oxygenation, control pain. We want to get those dilated arteries, or coronary arteries dilated by using nitroglycerin or morphine. We want to prevent clotting, and we want to decrease that myocardial workload. Brief perfusion therapy is typically sent to the cath lab. They have percutaneous coronary intervention where we go in and do ballooning and stenting and possibly use a fibrinolytics, which are going to help get rid of that clot and keep them from building up. If there is multiple areas of clotting, then the patient might end up with a coronary artery bypass. So the next little slide here just shows an example of what our normal PQRST looks like and the evolution of a cardiac myocardial infarction. Typically we have ST depression, and we're going to see that ST segment elevate. And it shows that in those second two there where you have that ST segment elevation that we recognize with the myocardial infarction. And then asystole. Of course, there is no measurable electrical activity from the heart. Again, check your patient. Make sure if there's any responsiveness. Check for a pulse. If there is no pulse, you want to do CPR immediately and call a code. When we look at heart blocks, there are several different types of heart blocks. We do see first degree, second, and there's two types of second degrees. You are not tested on this for this exemplar, but just know that a heart block is a delay or a block in that conduction. Typical causes are from acute coronary syndrome or an electrolyte imbalance and possible medication toxicities. So the heart block that we will talk about in this exemplar is your third degree heart block. So this is where the AV node is completely blocked. So you will see P waves and you will have QRS complexes, but they are working completely independent of each other. Treatment is going to be supportive care. We need to treat the cause of it and possibly have this patient on some sort of pacemaker, whether it's transcutaneous or a temporary pacemaker, depending on the cause, because there is decreased cardiac output when your P waves and your QRSs are not working together and they are not talking to each other. So here is a little example of a waveform with a third degree heart block. So as the blue little arrows are pointing at all your P waves, and then your red is your QRS that's kind of buried in there. But you see there is not a correlation between them. It is literally one is beating opposite of the other. And again, you do not have good cardiac output when you have this type of a rhythm. So the main treatment for a third degree heart block would be your pacemaker. Typically, we're going to start with putting that patient on temporary pacing pads that are attached to a defibrillator monitor. This is going to help regulate their heart rate and try to get it back into an organized rhythm. The patient may have a temporary pacemaker placed, which is introduced into that right ventricle. It is attached to wires and a battery pack that's outside of the body, or the patient can have a permanent pacemaker that is placed, and we'll show you some examples of those. Reasons for doing a transcutaneous or a temporary pacemaker on a patient with a third degree heart block could be possibly from a DIG toxicity. They might have had digoxin toxicity and they just need that medication to wear out of their system to try to see if their heart rate and that complex will go back into a normal rhythm. So here is an example of transcutaneous pacing. Again, this is just pads that are placed. They can either be on the front of the chest as shown, or one in front, one in back. This is an example of a temporary pacemaker. So this has one wire that is floated down into the right ventricle, and it is monitored by this little battery pack that is attached outside of the body. So it's a real important thing that we make sure that this is monitored or works off of battery power. So what's an important thing that we should keep at our bedside? Batteries, right? So we always want to check and make sure that we have batteries when we are using a temporary pacemaker. And then here is a sample of a implanted pacemaker. It is implanted underneath the chest wall, and the leads are floated through your vena cava into the right atrium and right ventricle. We see on the rhythm strip here, this is a pacer spike. So when you have a pacemaker that's working, you're going to have a little extra spike, whether it is atrial or ventricular, and sometimes it could be both atrial and ventricular. So we see those pacemaker spikes. Um, Real important that when we are looking at a patient with a pacemaker that we make sure that that pacemaker is showing those spikes and that it's working. When we have a failure to sense or a failure to capture, improper sensing, that patient has a capability of not producing, a right cardiac complex and having a decreased cardiac output. So if we see a patient that has a failure to capture or some sort of imbalance with that pacemaker, we want to make sure that we are notifying the doctors immediately, as this patient might need to go back to the cath lab to have the pacemaker checked. It might need a new battery. There's different things we can do to try to troubleshoot it. So here's a couple of examples that show a failure to capture on a pacemaker. As you see in the beginning of the top strip, you have pacemaker spikes for an atrial and a ventricular spike, and then nothing. And you also notice a difference in your QRS complex. The second picture here is showing where you have pacemaker spikes, but no QRS complex that is associated with it. And again, we need to make sure the doctor is aware of these complications immediately, because it could be, again, an electrode out of position or a faulty wire, a weak battery, or they just need to be returned and analyze how this pacemaker is working. So when we're looking at just some of our nursing management of a patient with dysrhythmias, we always want to know that any kind of an altered rhythm can cause impact on that cardiac output. So our patients might present with shortness of breath, pain, hypotension, fatigue, and if it's not recognized and treated, they can eventually turn to death. Sorry, my pacer's not working.